Hello, today we will be studying about strabismus, that is squint. It is a difficult topic, but then let me help you break it down into easier one so that you guys can really understand it. So how you define squint? It is a misalignment of the visual axis of the two eyes. Normally, the visual axis of the two eyes are parallel to each other in the primary position of gaze, and this alignment is maintained in all position of the gaze. When there occurs misalignment of the visual axis of the two eyes, this is known as strabismus or squint. Now, how to classify strabismus? Strabismus can be classified into apparent squint, that is the pseudostrabismus, latent squint, that is the heterophorias. Phorias means latent. Tropia means manifest. So manifest squint is a heterotropia, which is further divided into two, that is the concomitant squint and the incomitant squint. Now coming on to the pseudostrabismus, that is the apparent squint. So in this, the visual axes are actually parallel, but they appear to be misaligned. Alright, so in this case, the visual axes are actually parallel, but they appear to be misaligned. So in the first case, that is the pseudo-esotropia. What is pseudo-esotropia? This is an apparent convergent squint. It is associated with a prominent epicanthal fold. You can see here in this image there is an epicanthal fold which covers the normal visible part of the sclera, and hence it gives the false impression of esotropia, and it is associated with a negative angle kappa. So I will tell you in the next slide what negative angle kappa is. So this is angle kappa. Alright, so with the optical center, pupillary axis and the visual axis, the angle that it makes is this angle kappa. The angle between the pupillary axis and the visual axis. Alright, so that is the angle kappa. So in pseudo-exotropia, which is a divergent squint, apparent divergent squint, it is associated with hypertelorism. It is a condition which is characterized by the wide separation of the eyes, as you can see here. There is this wide separation of the eyes, and it is associated with a positive angle kappa. Now coming on to the second important type of squint, that is the latent strabismus, which is known as heterophoria. This is very important. We will be taking a considerable amount of time to understand this, as well as how to manage this and how to diagnose it. So first of all, what is heterophoria? It is a condition where the eyes have a tendency to deviate, but this is kept in check by the fusion, which is the normal binocular vision, as we have studied in our previous slides. When fusion is removed, how the fusion can be removed? By covering the one eye drifts away from alignment. So this is heterophoria. What is heterophoria? Heterophoria means the squint is not visible to the naked eye. So we have to evaluate whether the squint is present or not, and how we do this? We uh, remove the fusion, or by dissociation. How we do that? We cover the one eye, and hence the one eye drifts away from the alignment. Now coming on to the orthophoria. What is orthophoria? It is the ideal state where eyes remain perfectly aligned even without fusion. This is this is orthophoria. So it is mostly theoretical. Most people have a small amount of heterophoria, that is which is known as a physiological heterophoria. Now coming on to the type of heterophorias. So the number one is the esophoria. Eso means inside. It is the inward tendency. Eyes turn inwards. Okay. So the types of esophorias. So if there is convergence excess, there is more deviation at the near. Divergence excess means more deviation at the distance. So it can be non-specific, means similar deviation at all the distances. Then coming on to the exophoria, it is the eyes tend to turn outwards. It is of different types: convergence weakness, more deviation at the near, and divergence excess. There is more deviation at the distance. Non-specific means there is no significant variation with distance. Coming on to the next category, that is the hyperphoria. That is one eye. Hyper means up. So one eye tends to move upwards. The other eye is relatively lower, which is known as hypophoria. So it is how it is clinically described as: if there is right hypophoria, this means right eye is higher, and left hyperphoria means left eye is higher. Then coming on to the cyclophoria, that is the torsional deviation. So here the eye rotates around the anterior posterior axis. So the types are encyclophoria. Here the top of the cornea is 12 o'clock rotates nasally. This is very important. Whenever we say intorsion and extorsion, we define. So we define at nasally, top of the cornea. That is 12 o'clock, it rotates nasally, and excyclophoria, then it rotates temporally. Then coming on to the etiology of heterophoria. So first of all, we should learn about the anatomical factors. These are structural or physical variations in the eyes or surrounding structures that can disturb the normal alignment. The number one is the orbital asymmetry. So if the eye sockets are not symmetrical, the positioning of the eyes differs. This leads to imbalance in the eye alignment and hence heterophoria occurs. Coming on to the number second, that is the abnormal interpupillary distance. So if the interpupillary distance is wide, if there is wide interpupillary distance, this is the tendency for the eyes to drift outwards, which is known as exophoria. If there is a small interpupillary difference, here the tendency for eyes to drift inward increases, which is known as esophoria. Because eye positioning affects convergence and divergence demand, that is why abnormal interpupillary distance is very important. Third is the faulty insertion of the extraocular muscles. If muscles attached at the abnormal positions, their pulling direction changes. So this results in improper control of the eye movements. Then coming on to the fourth point, that is a mild extraocular muscle weakness. Slight weakness is in one or more muscles causes imbalance of the forces and hence leads to latent deviation, which is known as heterophoria. Then fifth cause is the anomalous central innervation, unequal or abnormal nerve signals to the two eyes, which this causes imbalance even if the muscles are structurally normal. Coming on to the sixth point, that is a variation in the macular position. If the macula is not perfectly aligned with the optical axis, the fixation differs. So this creates a tendency for deviation. So we have read about the different causes which can lead to phorias. Okay. Now these were the anatomical causes. Now coming on to the physiological factors. So these relate to the normal functional changes in the body rather than the structural defects. The number one is the age. In young individuals, there is more esophoria. Why? Due to strong accommodation and convergence. In elderly, there is more chances of exophoria because accommodation also decreases. Okay. On to the role of accommodation. If there is increased accommodation, this results in esophoria, and if there is decreased accommodation, this results in exophoria because accommodation is linked with convergence, that is AC by A ratio. Now coming on to the role of convergence. Excessive convergence use results in esophoria, example in bilateral congenital myopia, and second is the reduced convergence use, that is results in exophoria. Here example is the presbyopia. Then coming on to the dissociation factors, when binocular vision is not used equally, the fusion weakens. This leads to exophoria. Example is using one eye continuously, for example in case of a uniocular microscopic users and watchmakers using magnifying glass. Then factors predisposing to the decompensation. First is heterophoria becomes symptomatic and this may turn into the manifest squint. There is poor fusional reserves, weak ability to maintain the alignment, general debility, low health, psychological factors like stress, neurosis, psychosis, high visual demand jobs like precision work like fine detailed tasks as well as the advancing age. These are all the factors which lead to decompensation. Physiological factors mainly affect the balance between the accommodation and the convergence. When this compensation fails, latent deviation becomes symptomatic, that is decompensated heterophoria. Now coming on to the symptoms of heterophoria. First of all, we will learn about compensated heterophoria. Compensated, as the term describes, is there are no subjective symptoms. Here, the deviation is controlled by the fusional reserves, which is manifested by the neuromuscular power. Here, there is desire to maintain the normal binocular vision, and here the patient is usually asymptomatic. Coming on to the decompensated heterophoria, here when fusional reserves fail to control the deviation, then only symptoms appear. Now, first of all, what kind of symptoms will appear in case of a decompensated heterophoria? First of all, there will be symptoms of muscular fatigue, which is known as asthenopic symptoms. Here, due to constant effort to maintain the alignment, there is headache and eye strain, which is worse after prolonged visual work and it is relieved by closing the eyes. Second is there is difficulty in shifting the focus from the near distance transition, which is uncomfortable. And then there is this photophobia, which is not relieved by dark glasses. It is relieved by closing one eye, which is very important to diagnose decompensated heterophorias. Coming on to the symptoms of the failure of binocular vision, then there is blurring or crowding of the words, intermittent diplopia, and the intermittent squint. Coming on to the defective postural sensations, here difficulty in judging distance and position, which is very important in case of athletes as well as in pilots. Now, what is a key concept? If it is compensated heterophoria, then there are no symptoms. If there is a decompensated heterophoria, there will be fatigue, which is the asthenopic symptoms like headache, blurring of vision, as well as there will be binocular vision problems, and there will be problem in the depth perception issues, which is very important in cases of athletes as well as in pilots, because they will face difficulty while landing the aircraft. Now, examination of a case of heterophoria. So, for first of all, we need to test for vision and refractive error, which is very important in any case that presents with squint. This is a fundamental step in evaluation. Refractive errors may cause the patient's symptoms, for example, like eye strain, headache, diplopia, as well as contribute to or even produce the heterophoria. Here, the cycloplegic refraction is preferred, especially in children, because this eliminates accommodation and it gives an accurate measurement of the refractive error. Both distance and near vision should be accessed. Coming on to the second test, that is the cover uncover test. So this test is used to detect the presence and the type of heterophoria. Very important. So what is the procedure? The patient is asked to fixate on a far away target. One eye is covered with an occluder, like here. One eye is covered with, while the other eye maintains fixation. The covered eye is then uncovered after a few seconds. Okay, so now here on uncovering, so here the occluder is on the eye, that is the eye that is covered. Now when we remove the occluder, if the eye moves inwards, means on uncovering, if there is inward movement, then this means this eye is in exophoria. So direction of the movement indicates the type of heterophoria after uncovering. When we, this is the covered eye, when we remove the cover, the direction in which the eye moves, if it moves inside, the opposite, so therefore the phoria will be in the opposite direction. So if the eye is moving inside after we uncover the eye, so this means there is exophoria. So inward movement of the eye in the, as in this case, helps us to reach to a conclusion that this eye is having exophoria. Similarly, if on removing the cover there is outward movement, then that is esophoria. If there is upward movement, then there is hypophoria, and if there is downward movement, then there is hyperphoria. Okay. Now, the speed of the recovery also tells us something. If it is rapid, then there is good fusional control, and if the speed of recovery is slow, so that indicates a poor control. Okay. Coming on to the another test, that is the prism cover test. So what is the purpose? Its purpose is to measure the degree of heterophoria. It quantifies the deviation in prism diopters. If the whether the deviation is present or not, it can be checked by the cover uncover test. Now, when we have to quantify the deviation in prism diopters, then we need to have this prism cover test. So what are these? This is a prism bar. Okay, so this prism bar, it helps us to quantify the deviation. So there are two types of prism cover tests. One is the alternate prism cover test, which is the most commonly used for heterophoria, and then there is this simultaneously prism cover test, which is less commonly used. We will be talking about the alternate prism cover test. So in this, the patient fixates on a target, either distant or near. First of all, we will see at a distant target, and then we will try to see at a near target. So the examiner alternately covers one eye and then the other, and hence breaking the fusion continuously. A prism is placed before one eye, the strength of the prism is gradually increased. So the goal is to neutralize the movement. No movement should be seen when switching the cover. So basically, how the prism is placed. So prism is a triangular structure. Okay? So apex towards the deviation. So this needs to be remembered, APD. So the apex should point towards the deviation. Okay, so in this way, we will come to know the exact quantification of the forias in prism diopters. Okay, so how do we interpret it? When there is no refixation movement is seen, then the deviation is neutralized. The prism used, strength used at this point is equal to the amount of heterophoria. So if there is isophoria, then this is a base out prism. This means apex should be inside and the base should be outside. In case of exophoria, we will use a base in prism. Hyperphoria, we use a base down prism before the affected eye, and in hypophoria, we use a base up prism. Now coming on to the Maddox rod test. So what is the principle? It is based on the principle of the dissociation of the two eyes. So what is a Maddox rod? It is a series of cylindrical lenses which converts a point of light into a line image. So this prevents the fusion and allowing the latent deviation to become manifest. This is another very important test. So how does it help? So you can see this is a Maddox rod. Here these are cylindrical lenses which are placed. So now it is a red glass rods. It point light source is required and a trial frame is required. Now coming on to the procedure, the patient fixates on a light source at 6 meters for a distance test and a 33 centimeters for a near test. A Maddox rod is placed before one eye. Usually first of all we place it usually on the right eye with the rods horizontal. If the rods are horizontal, they will produce a vertical line. If the rods are vertical, they will produce a horizontal line. The other eye sees the point of light. So So how do we interpret it? For horizontal deviations, Maddox rod is placed horizontally. In this case, a vertical line is seen. Okay, so if the line passes through the light, then there is orthophoria. Here, the line passes to the right of the light, then there is exophoria. If this line passes to the left of the right, then there is this isophoria. Okay, for vertical deviations, for vertical deviations, if the line passes through the light, there is no vertical deviation. If the line passes below the light, then there is hyperphoria. If the line passes above the light, then there is this hypophoria. So now let us see with the help of an image. Okay, so a prism is added until the line passes through the light. The prism power required is equal to the amount of hydrophoria in prism diopter. So what are the advantages? It is simple and quick, it is sensitive for detecting small forias, and it is useful for both distance and near. Uh, Now in this particular diagram, so first of all, we will see this right side image. In this case, the horizontal red lines can be seen on the Maddox rod. So if the lines are horizontal, the light source, when we project a point of light, it will get converted into a vertical beam of light. So if the vertical beam of light is on the right side, then this is iso. If it on the left side, then it is exo. Okay, similarly, if the vertical lines on the Maddox rod are vertical and here the line of light will be horizontal, so if it is above, then it is hyperphorias, and if the line is below the point source of light, then this is right hyperphorias. Okay. Coming on to the treatment of heterophorias, treatment is indicated only in case of a decompensated heterophoria. First of all, the most important thing is we need to correct the refractive error. Okay. Number second, orthoptic treatment is needed when no refractive error is present or symptoms persist despite the glasses. So here we can have the synaptophore exercises or home-based exercises, that is the pencil push-up exercises. So the aim is to improve the convergence insufficiency as well as to increase the fusional reserves. Coming on to the prism therapy, this can be used in selected cases of hyperphoria or symptomatic esophoria or exophoria. Here the prism is given with apex towards the direction of the phoria, as I have already told you. So it usually corrects half to two-thirds of the deviation and there is no full correction. Coming on to the surgical treatment, it is indicated when symptoms are severe and persistent and they are not relieved by other treatments. Here the aim is to strengthen the weak muscle or weaken the strong muscle. Thank you. Thank you so much. I will see you in the next slide where we start discussing the strabismus, concomitant strabismus. Thank you.